Again. May I ask for another round of applause for our So I am pleased to introduce my distinguished panel. First, Dr. Jillian Lampert will be speaking on challenging access to care for eating disorders since parity has passed and the potential for the essential health benefits. Followed by Holly Meerbaum, who will talk about trends in treatment access since the passage of parity. And then I am pleased to welcome Kitty Weston, who is past EDP president and who will be speaking about being an advocate from Minnesota who has successfully made efforts in her state so that eating disorders would be included in the EHB. And then I'm very pleased to introduce my good friend, Jay Azoff, who will be talking about how long-term treatment is safe for life. And lastly, I am honored to introduce Dr. Jillian Kogan, who is going to wrap up by telling you why we need the FREED Act now and how we, together with our voices today, can save the lives of people tomorrow. So please let me welcome Dr. Jillian Lampert.
Good afternoon, everyone. Thank you for giving your time to come to Washington and to learn about the initiatives we're having. If you work on the Hill, thank you so much for coming to our briefing and sharing your time with us. I just want to put myself in context a little bit so you know who I am besides whatever it says on the briefing photo. So I'm a researcher, I'm a clinician, I'm an administrator for a treatment program, I'm an advocate, and I think probably most of all in this room, I've been recovered from an eating disorder for 20 years. I'm here to talk about a problem that we thought was fixed, but it's not. So we brought our voices to Washington to ask those who represent us in Congress to help us fix it, and it's a fixable problem. So in 2008, the Paul Wellstone and Pete Domenici Mental Health Parity and Addiction Equity Act, which we call parity because that's a lot easier to say, was passed in order to improve access to care, which was a great thing. So parity requires insurance companies to ensure that things like co-pays and deductibles and treatment limitations applied to mental health or substance abuse are no more restrictive than those applied to medical or surgical benefits. So we in the eating disorder world cheered this victory. We thought it would help people struggling with these life-threatening illnesses access the care they need and go on to live full, productive lives. We thought that parity would bring, well, parity, which is equality in physical and mental health. You see, the spirit and intent of the law was to fix this problem that mental health and addiction were being treated like second-class citizens compared to physical health. And the idea was to level the playing field, to make it a fair game, to make sure everybody was playing out of the same playbook. But we still have a big problem. The playing field is not level. It's not a fair game in a lot of ways. And things are still not equal between mental health and physical health. Why? For a number of reasons, but in part because the final rules that fully outline how the law needs to work are not done. In the absence of these rules, the biggest offenders on the playing field are just simply making up their own rules. And people with eating disorders and their families are losing. So without the final parity rules to provide more direction on proper implementation, many people with eating disorders, maybe some of you in this room, are still being denied the mental health care to which you're entitled under parity. And without the rules, parity has not been fully implemented. The law isn't fully functional, and the spirit and the intent of the law is being ignored. So the problems with accessing eating disorder care that still exist, despite parity being the law, they show up in multiple ways. And they show up in the form of arbitrary limits on treatment, denial of benefits in the middle of treatment, lack of transparency in medical decision-making criteria, and really unequal application of authorization requirements. So let me give you some examples of those sort of big phrases. Somebody has a hard enough time getting access to treatment, and once in treatment, insurance companies devise these limits on care that they seem to sort of pluck out of thin air. They deny benefits in the middle of treatment and use medical criteria to make these decisions without making them available to clinicians and the person being treated. So in the medical realm, this would be like saying, you know, that's great, that broken leg you have is starting to heal in that cast we just put on, so we're just going to take it off. Or, we're going to get that cast, we're going to take that cast off we agreed you needed, and now you should just get used to the pain because, we've decided you actually don't really need that treatment any longer. Or in addition, and we're not going to tell you what criteria we use to make that decision about your cast. You just, trust us, you just didn't fulfill those criteria. So some insurance companies also have this unequal application of authorization requirements for the providers. So in addition to what the individual hears, the providers hear really interesting things. So authorization, for those of you who don't know, is the process by which insurance companies issue approval for care. So an example of this might be in our world, somebody goes into treatment, they need to restore, let's say, 15 pounds to get anywhere near a minimally acceptable body weight to move to a lower level of care. And at our community treatment standard of about 3 pounds per week, that's going to take a while, right? It'll take a little over a month. And the insurance company requires the treating clinician to call for continuing reviews on that patient every 2 or 3 days. That's like asking a clinician who's treating a woman going into labor to call the insurance company for authorization for care every 3 minutes to see if it's okay still to deliver the baby. And I don't deliver babies, but I don't think that probably happens in labor and delivery rooms around our country. And those are the kinds of games that are being played on our playing field right now. And then additionally, as if you don't feel bad enough after that list of problems, there's been considerable elimination of coverage for particular levels of care, really arbitrarily limiting the scope of treatment available in mental health. And this sort of limitation in the scope of treatment shows up in the eating disorder world with particular regards to residential level of care, a level of care that's commonly accepted as part of the clinical standard of care in the community. These specific levels of care are increasingly showing up on lists of exclusions because certain services are thought to have no medical analogy. And this means that plans refuse to cover a mental health service because they say there's no similar or analogous service in the medical side. So I went and looked at the definition of parity because I really wanted to know what the word meant. So parity is not defined as exactly the same. Parity is defined as equivalent. So I thought, equivalent, that's interesting. So here's an example. 5 plus 1 does not look exactly the same as 3 plus 3. Yet they're indeed equivalent. That's parity. That's equivalency. It's true that longer-term, 24-hour, 7-day-a-week residential treatment for a debilitating eating disorder doesn't look exactly the same as 24-hour, 7-day-a-week care for the victim of a gunshot wound. Yet from a let's treat the problem perspective, they look pretty equivalent. Furthermore, because the problem's still not bad enough, it doesn't seem that eating disorders are being eliminated just because some insurance companies are confused about the definition of parity and they haven't looked it up yet. That's not really the problem. It's not that they're really failing to realize the equivalency. There's more to it than that. It seems clear that they question the legitimacy of eating disorders as real illnesses, despite clear evidence that eating disorders are complex, brain-based illnesses with strong biological and genetic underpinnings. These are not behavioral problems gone awry. We all know that. We may be some of the few people that know that is very true. We need to do a lot more education because I think of this really false belief. Exclusion for eating disorder treatment is often put in the context of procedures and activities that we either denote as elective or perhaps experimental. So a policy I read just yesterday said, the back of the policy where they say we exclude the following list of things. So the following list of services, and I quote, are not typically covered, this following list of services are not typically covered under this plan. Assisted fertilization, carbon dioxide therapy, I don't even know what that is. Probably very important, I don't know what it is. Cult deprogramming, crystal therapy, residential treatment for eating disorders, and summer camp. I've never asked my insurance company to pay for my kids' summer camp. One of my own patient's policies said, she brought it in and said, look at this policy. It said, the following are not typically covered under this plan. Wilderness camping, eating disorders, and elective cosmetic surgery. And to add insult to injury, it said after that, we do cover weight loss services. For an illness that has the highest mortality rate of any mental health illness, that has established treatment guidelines that are the standard of care across the field of experts around the world, I don't think treatments for eating disorders qualify as elective. So we're not at parity yet. But fortunately, there are some things we're going to do to fix that problem. And one of those things we're doing today. Today we'll be urging senators and Senate staff to sign on to a letter written by Senator Tammy Baldwin urging the administration to complete the final parity rules, to make them strong and fair, to take into consideration the comments that have been submitted already outlining these concerns, so that eating disorders are taken seriously. And I urge any Senate staffers in the room to consider asking your boss to sign on to this very important letter. The other thing we're going to do is be sure eating disorders don't get carved out of plans going forward. I don't want to see us behind crystal therapy and carbon dioxide treatment anymore. So for this objective, we look to the essential health benefits. So a provision in the Affordable Care Act requires insurance companies to cover 10 broad categories of care, called essential health benefits. One of the 10 categories is mental health and substance abuse service benefits, including behavioral health treatment and services. Another long list, but it says, coverage of the essential health benefits must provide parity between medical and mental health benefits. So this law is again repeating what it says in parity. The new law clearly says that mental health is to be considered on the same playing field as physical health. And this is great news. I'm excited about this. And we all should be excited about this. But I'm still worried. Why am I worried? Because in theory, eating disorders are included in the essential health benefits. We are a mental health disorder. We should be in line item number 5 on the essential health benefits because they're in there. But we've been carved out of those policies time and time again, and I'm afraid it will happen again. So we need to make sure that our voices are heard and that we stand up against the violations of parity and the Affordable Care Act if that happens again. So we need to be watchdogs for what happens in each of our states as the states carry out the Affordable Care Act. The law requires each state to select a benchmark insurance plan that must cover essential health benefits. So this benchmark sets the standard in that state. So clearly that is a very important insurance plan. Some of those benchmark plans look like great plans across the country. They support optimal eating disorder care, and some benchmark plans do not look so great. So the EDC surveyed the benchmark plans from all 50 states, plus the District of Columbia. And this survey, which if you want to read it, is on the EDC website, showed a wide disparity in anticipated mental health and substance abuse service coverage between states, particularly as it relates to residential care and eating disorder care. And this disparity is of great concern for people struggling with eating disorders and other mental health issues across the country. So in our review, 27 of the benchmark plans severely limit mental health services, with few actually specifically excluding residential eating disorder treatment. Once again, many of the plans have day limits on mental health care and exclusions for residential services or eating disorders in that list of completely unrelated and mostly elective items that are typically not covered. So given that similar limits are not seen in the medical side, remember parity is about equality or equivalence between the two sides, it seems that this disparity should not be allowed under mental health parity or the ACA. In contrast, our review indicates that 24 states have strong mental health coverage without any of these non-equitable service limits. Many specifically include residential treatment. They actually say in the thing, we cover residential treatment for eating disorders. It's fantastic. Vermont and Maine seem to have the strongest coverage for eating disorders, and numerous other states have strong coverage with no stated day limits or exclusion from care. And for being from Minnesota, which has had a strong history of coverage, we were a little disappointed to not have Minnesota be at the best top right up there. It's close, it's really close. But I have one on Kitty that I lived in Vermont for 5 years. So I feel pretty good about that. So with half of the states, including equitable coverage for mental health and substance abuse services, there's really strong evidence that plans can and do actually cover the services that we need. Good coverage for eating disorders is possible and affordable. And there's a pressing need for the other half of the nation to provide for inclusive coverage of these illnesses. As a nation, we're going to move forward with implementing the Affordable Care Act state by state, and it's imperative that we pay close attention to the equitable and adequate access to care for people with eating disorders and all mental health conditions. We can treat eating disorders, absolutely. People can absolutely fully recover and go on to lead fantastic, productive lives and come to the Hill and talk to a lot of people. And I'm reasonably sure, actually I'm quite sure, that we don't want whether you get well or you lose your life because of an eating disorder to depend on the state in which you live. We can do a lot better than that. Thank you.